we are going to talk about major treatment decisions during major illness. You will see the transition of how things go for many people. We have a story. We're going to tell you a story. The story is full of issues. It is not one single person's story, but the accumulation of several people that we have looked after. This might be a very overwhelming situation for you if you have any recognition of any of these issues that it may have happened in somebody in your life or yourself. It is our intent to teach and advise and not frighten. Okay? If any of this is uncomfortable, please speak up during the panel. We are not going to be talking about brain death in this case, but there certainly are multiple thoughts that we both have. And so I just asked somebody to bring that question back up during the panel and we can talk about it. So, Muhammad, the most common first name in the world, not your family member. 67 male, presentation, shortness of breath. New diagnosis of lung cancer. Additional issue, during staging, found to have a condition called severe aortic stenosis. Now, shortness of breath. Shortness of breath is incredibly common as a finding. Sometimes you can be short of breath because you have a major illness. Sometimes you can be short of breath because you have a cold. Shortness of breath is common. Staging. Staging is the process of figuring out what type and to the extent of the cancer that you have, as well as of planning treatment. Aortic stenosis is a hardening of the major valve separating the heart and body, of which there are numerous treatments available. Okay? So, aortic stenosis in this guy is found to be treatable. His lung cancer is identified as stage 3. He has some spread, but he has options including surgery, chemotherapy, and radiation. He is deemed to have years of life with appropriate treatment. So, by principle, he must undergo valve treatment, as Maulana has stated. When we have options and when we have capacity for life, then we must pursue that. So, he must undergo valve treatment prior to lung cancer treatment because that's just how his body is going to be able to tolerate both these concurrent conditions. So, he has 2 major illnesses, but both are highly treatable, but serious. He's otherwise relatively healthy and could have many years of quality of life ahead. Again, in the Islamic principle, he must try and preserve his life in this situation. So, we go quickly now. He undergoes valve treatment. He undergoes the lung cancer surgery. He undergoes several rounds of chemotherapy. 2 years on from the initial diagnosis, he's thriving and well. Alhamdulillah, the case is over. Not so fast. Not so fast. So, 1 year from there, he's now 70 years old. Notices that his pants are looser than before. He's also starting to feel short of breath on his walks. People don't come to the doctor and say, I'm losing weight. They say, my pants feel funny. They say, my clothes don't fit the same. My wife noticed that my face is a little bit gaunt. I can't walk as far as I used to. So, he's been keeping up with his doctor's appointments until now. He's had no issues. But he has a new diagnosis. He has a recurrence of the lung cancer that is now spread to his heart, lungs, bones, and brain. So, he's now deemed incurable, but chemotherapy can be given to slow the spread and give him a few additional months of life. So, what does incurable mean? Incurable means it will never be gone, but it may be able to be controlled. Controlled means that the spread can be slowed or it can remain the same. This is a way to prevent symptoms of the cancer, including pain, more shortness of breath, more fatigue, but also as a way to prolong his life. So again, what principles apply? Preservation of life is certainly one of them, but as again Maulana alluded to, accepting treatments and understanding their scope. Refusing treatments and understanding the consequences. If you accept a treatment and it shortens your life, you needn't accept that treatment. But if you refuse a treatment and it prolongs your life, you have to understand the scope of what that involves and what sort of burden that would place on you and what sort of burden that would place on your family and your body and everything else. So, again, all of these are very nuanced positions, and this is where the difficulty comes in for people. We find that when people are in these sorts of situations, it's often like staring at a buffet menu. You know that you can't eat everything, but that doesn't mean they offer you everything. Moreover, you don't actually know what's good for you or what's not good for you, what you're going to tolerate and what you're not going to tolerate. And sometimes you pick things up and you think, I don't want that. And sometimes you don't pick things and you think, I really did want that. But then it's too late. So the issues are that you have to understand, when you are this person, when you have this person who's your family member, what you need to understand is scope. You need to understand extent. You need to understand how far down this rabbit hole am I going to go. So Muhammad chooses to go ahead with chemotherapy. He undergoes several weeks of chemotherapy, but after each round he feels worse. He gets readmitted to hospital with worsening shortness of breath and swelling. So because of his valve procedure in the past, he has an ultrasound of his heart, an echocardiogram. He's found to have a large collection of fluid around his heart. The presumption is that this fluid is from the cancer that's invaded his heart sac. They offer him a drainage for symptom relief as well as for preservation of life. This fluid compresses your heart, prevents your heart from beating properly, and is a life-threatening emergency. He feels desperate and he chooses to undergo the drain. The drain works for a few days and then it gets clogged. They offer him another drain, but they tell him likely that it will get clogged again. They then advise him that the only way to properly drain the fluid around the heart is to have a small heart surgery to open a hole to allow the fluid to drain away. So now he has another major decision. He undergoes the heart surgery. He has some relief, but he's transferred back to the cancer hospital. He tries to get stronger in preparation to go home, but the pain and the shortness of breath are limiting. He is then referred to the palliative care team to help with symptoms. Is this your turn? Normally when I say palliative care team, I walk away now, and then she takes over. His pain and shortness of breath are better controlled. He is unable to walk more than a few steps and has trouble cleaning and feeding himself due to profound weakness. There is a plan for a family meeting with all of the teams providing care for him. Now, palliative care team takes over. Yes, absolutely. Yes. Yes. Correct. So the procedure in this case is a in the context of heart surgery, this is a minor procedure. Okay, and what it is to open up a space in the pericardium, which is the heart sac, to allow the fluid to drain out. It's a more permanent solution than putting a drain back in. Now, in this case, many people undergo these sorts of procedures for symptom relief. It is reasonable to undergo a symptom relief procedure like this, okay? Certainly, certainly. In my experience of doing these for people, they are very late stage. And when we do these pericardial windows, is what they're called, for malignant effusion, it was what it's called, people are often dead within weeks of these procedures. And so, as was stated, if there's no survival benefit to this, and there isn't, you do not need to do it. Any other questions before I step down? Yes? Yes. Yes. The chemo. The second round of chemo. Yes. Great question. So here, Maulana stated very nicely, and we can bring this up at the panel again, okay? But he's incurable. And so it is my opinion, Maulana can overrule, is my opinion that when you're incurable, you do not have to do things. His time is limited, okay? He can choose not to do this. The chemotherapy is purely symptom management in this case. It is not life preservation at this point. He will die from this cancer. It's just a matter of time. And so I do not believe that he has to do this. That's key. That's key. That's key. Yes. Any other? Yes. I think so. There's a nuance to that. But ask your question, then I'll tell you the nuance.
The question is, if you can consider doing molecular or genetic staging of the tumor to see if there's a potential clinical trial that might offer a precision oncology option, right? Whether it's a small molecule or immunotherapy or something of that sort, that could potentially, provide, an extra avenue. Do we not need to consider that before we pass them on to palliative?
So I will say, yes, it's usually done right at diagnosis. So they do, I know here in Canada, they do that right off the bat, and all the treatments offered are based on the genetics of the cancer. So usually by the time you're saying somebody is incurable, they've got to the point where the oncologist has explored everything, including clinical trials that may be available.
Hold on, I want to answer the nuance first. One of the nuances of an incurable cancer is also prognostication, which she's coming to in a second. In this particular case, this is a lung cancer with diffuse metastatic spread, whose prognostic term is limited, right? There are certain cancers whose prognostic term are years, okay? And so their chemotherapy, even though they're incurable, okay, their chemotherapy is very controlling, and their symptom burden in those cases is much less. And so again, this is where the nuance of this comes in. We've particularly picked a case that is got a finite end. There are certain prostate cancers, for example, that can last for years. There are hematological blood cancers that can last for years on appropriate chemotherapy, even though they are incurable. And so in those cases, you have to make decisions about what your life expectancy would be in that case, based on what you have available. And so, but we've specifically picked something that is got a finite end.
You have one question here again, sorry.
Yes.
Assalamu alaikum. This was a 70-year-old man with terminal cancer. What if it was a 40-year-old man with terminal cancer?
Age doesn't matter. Honestly, age doesn't matter. I see patients from their teens to their 20s, and honestly...
You would still recommend no treatment? And would Maulana endorse that, please?
It has nothing to do with age. It has all to do with the stage at which the illness is at. And so, unfortunately, bad things happen to young people, and their time can be limited too. And I'm seeing it more and more in this day and age. Younger and younger patients are getting diagnosed with incurable cancers earlier and earlier in their life. So it truly has nothing to do with age, but to do with that.
My second question is that if you are basing your conclusions as a physician on prognostic indicators, right? You have those curves, the Kaplan-Meier curves, etc., which will tell you basically, give you the authority to tell the patient that your chances of survival are very little, okay? But is that acceptable by the Sharia? I mean, we know that God can give that person a life for 10 years more. And we've seen, I'm sure you have seen, patients with terminal cancer yet living for another 10 years.
I think it depends on the medical situation, and I think we have to trust our medical professionals when they give their opinions on what they perceive that the prognosis is. In the end, we can't force or, make people do things that they want to do against their will. When we kind of here in the West, when we talk to patients and tell them their options, ultimately, the decision is up to the patient as to what they do. But what I will say is we will not offer treatment that we think will cause harm to the patient. That is something that we are morally and ethically obliged not to do. And actually, our medical license can be taken away if we give patients treatments that we think will do them harm. So we will categorically not do that. But otherwise, really, we can talk to them about the options, and then the autonomy goes to the patient.
Thank you.
I want to just add one quick point before we carry on. There's a reason that miracles are noteworthy. They are exceptionally rare events. This progression is our life, is every day in our life. If there is a noteworthy case of somebody recovering from some, they gave me 2 weeks of life and here I am 10 years later sort of situation, that's a noteworthy story. That makes the news. That makes everything, right? So, but for the one that does do all of that, there are hundreds of thousands who do not. And so our opinion is based on the hundreds and thousands, not the one. And our progression of this story is based on the hundreds and thousands, not the one. Okay, we're going to carry on the story. Yes. No, it's okay. We are enjoying the engagement. It's on now.
The patient has a choice as to refuse treatment,
Yes.
right? And then you take over and, you control the pain and suffering and all that, right? And that's about it. Control the pain and the suffering and all that, and it goes for another year, 2 years, 5 years.
You're preambling the story. Sorry. We'll see how it goes. Yes.
Are we allowed to sign a DNR at this point?
We're getting there.
Yep.
We're getting there. We're getting there.
Yes, I'm
We're
going to
getting
do.
there. Yeah. Yeah.
Yeah. So now we've come to the point where he's had this pericardial effusion drained, and we're now wondering next steps because the patient really isn't making any progress in hospital and is really quite weak. So the hospital arranges a family meeting which has the patient there, the family there, the oncology team there, and the palliative care team. The oncologist says that the patient is too unwell to undergo chemotherapy. The fact that he's just so weak, unable to mobilize, means that the chemotherapy would be doing more harm than good at this stage and would actually cause him to get more unwell. And for that reason, the oncologist has said, I'm not going to give any more chemotherapy in this case because now the risks outweigh the benefit. And the oncologist gives a prognosis of less than 3 months, which I, as a palliative care physician, would agree to in this case. And this is when we talk about code status as well. And we talk about changing code status to allow natural death or do not resuscitate. Now, I just wanted to talk a little bit about do not resuscitate, because people really, I think, get confused about when do not resuscitate is actually recommended. Do not resuscitate is recommended in a situation where we know somebody has an incurable illness. And when we're talking about resuscitating people, it's actually the point when somebody's heart and lungs have stopped. So they have actually died, and we are trying to bring them back to life. And we know in situations where patients have an incurable illness, such as cancer, that the chances of bringing someone back to life is less than 1%. and those patients will end up on life support, and most of them will not be able to get off life support. So that's what Maulana Rizvi was talking about, is not putting yourself in situations where you know that there will then be difficulty. And being put on life support from an Islamic Shia perspective is very difficult because you cannot then withdraw life support. So this is why, in this situation, a DNR or an natural death would be the most appropriate thing to do. So they talk about this, and a decision is made to make the patient do not resuscitate. And then they talk about, where do we go from here? The patient is not progressing, it's very difficult. Is home going to be manageable with family supports, or do they need to think about somewhere like a hospice or a palliative care unit where they'll be able to manage the patient's symptoms and quality of life for the rest of their life? Typically, hospice and palliative care units admit patients who have a prognosis of 3 months or less, and this patient, Muhammad, would qualify in this case because he is in that time period. So they're thinking about this, but in the meantime, Muhammad is in a lot of distress about hearing about his prognosis, and he calls his palliative care doctor whilst his family isn't there and says, "Tell me, what is medical assistance in dying?" And you know what? This is a common case, and it does affect our community. So people think, assisted dying is not allowed in Islam. Why are we even talking about this? But I can tell you that from experience, Muslim patients, our own community, have asked about medical assistance in dying. So I just wanted to talk a little more about it. So it's been legal in Canada as of June 2016, and there's a whole bill that's passed through Parliament. I'm not going to go through all of the criteria, but essentially anyone who's an adult who has an irremediable medical condition, so a medical condition that can't be cured, can ask for medical assistance in dying. And the way the process works is they have to sign a consent form that was initially had to be witnessed by 2 people. Once that form was done, then 2 assessments have to be completed by 2 separate physicians who kind of go through the certain questions, asking the patient why they would like to undergo medical assistance in dying. If they can kind of explain themselves in a rational way, then they would be deemed eligible, and then they would have the procedure after a 10-day wait period minimum. Now, there's been an update to the legislation since 2016, and now they've included eligibility criteria for patients whose death is not reasonably foreseeable. And there are some kind of safeguards to that, including a 90 wait day period. But essentially, anyone who feels that they have any sort of illness that causes them suffering, even though death may not be in the foreseeable future, can actually ask for assistance in dying. And they've eliminated the 10-day kind of wait period. And they've also kind of made it so that you don't have to ask for explicit consent at the time of the procedure. You can sign pre-consent and then have the procedure even if you lose the ability to give consent right at the end. So as you can see, kind of from 2016 till now, there's kind of been a much loosening of the criteria, and it's become easier for patients to receive medical assistance in dying in Canada. So I wanted to talk a little bit about kind of what drives medical assistance in dying, especially kind of from a patient perspective, and why it's important for us and our community to think about this. I often find that people have physical suffering that might drive it. So they might have uncontrollable pain or shortness of breath, and that's driving their want to die. So kind of making sure that their patient's symptoms are well controlled is really, really important. And they have psychological suffering as well. Kind of terminal illnesses, whether that be cancer, heart disease, lung disease, it's been shown that they cause severe anxiety and depression in a number of patients. And, anxiety and depression is a medical condition. It needs to be treated, whether that's with medication, whether that's with talking therapies, it needs to be addressed. So making sure that the psychological needs are addressed is really important. And then there's spiritual distress as well, and I think we as a community often don't recognize that as kind of for what it is, and don't see it early enough. And, you know, people who are suffering, they may question their faith. They may ask, you know, why has God put me in this position? And, you know, we really have to be able to help our patients who are expressing spiritual distress and really help them come to terms with what is happening to them. So it's really important as a community that we band together and have the resources to help people in spiritual distress. And then, as Maulana Rizwi kind of alluded to, medical assistance in dying is absolutely forbidden in Islam, but that does not mean that people will question and ask for it. And I do personally know Muslim patients that have undergone MAID as well, unfortunately. So we're going to carry on. So the palliative care team recognizes his distress and refers him to a psychologist in the hospital for talking therapy and gives him medication to manage his anxiety. The patient and the family decides they want to take him home, so he goes home with increased supports at home, including a daily nurse who visits to make sure that his symptoms are controlled, and frequent palliative care doctor visits as well for medication changes. So as time progresses at home, he's getting weaker, he's not eating and drinking, and he's sleeping most of the time. Now, family is worried about lack of nutrition and ask about nutrition and hydration at the end of life. And I really wanted to emphasize this because this is a question I get asked every single day. When people are dying, their body is slowing down and their organs do not work in the same way, and therefore they cannot process food and nutrition in the same way you and I can. They don't feel the same hunger and thirst as you and I do, and for that reason they do not need hydration and nutrition beyond what they themselves want. So I always say, you know, if a patient is awake, alert, able to sit up, able to safely drink or eat something, great, give it to them if they're asking for it. However, if they're not asking for it, please do not force feed them. Please do not force them to take drinks in, because really this is a way of their body telling them that they do not need this. And then, you know, people ask about, oh, okay, it's all well and good. We won't give it through their mouth. What about giving them fluids through their vein? And I say the same thing again, is that their body cannot process any of these fluids, and actually it causes more harm than good at this stage. So all the fluid you put into the vein comes out, leaches into the tissues and makes people swollen, leaches into the lungs and causes the lungs to get wet so the patient can't breathe. It leaches into the gut and causes the gut to become swollen. It really has negative effects. So really, at this stage, we shouldn't be doing anything that is harmful to the patient. And for that reason, at the end of life, whether that's the last few days, the last few weeks of life, we really shouldn't be doing artificial hydration or nutrition. And I really wanted to emphasize this because it comes up every single day. So now we're approaching the last days of Muhammad's life. Unfortunately, his agitation and restlessness are increasing, and his family is having a really hard time watching how distressed he is, despite the palliative care doctor and nurse coming in and increasing his medications. The palliative care team has suggested transferring him to a hospice to help manage that distress and lessen the burden on the family. Here in Canada, a nurse might be able to only come once or twice a day, and the burden really falls on the family to administer medications and know kind of when to give those medications and provide most of the care. So it really is quite burdensome and distressing for families to be able to manage this. And we do have places like hospices and palliative care units available where there's nursing 24/7, there's personal support care workers 24/7, and specialized doctors there available to kind of make those medication changes and do all the cares for the patient. So The family decided that this would be a good idea, and a week later, he passes away in hospice, where his restlessness and agitation were much, much better managed. So, concluding thoughts. That was a lot of information when we went through a lot of concepts. As we kind of said, this wasn't one case. It was a fictional case, but it's a case that we deal with on a day-by-day basis. And we encompass lots of the issues and principles that we come to from both a medical and Islamic perspective. And we kind of wanted to open up the dialogue just so that, because we know that we as physicians deal with this on a day-to-day basis, and you as patients and family members will also come across this as well. So we wanted to kind of make sure there was clarity between all of us.